I'm Tamara Thomas, editor-in-chief of UrbanHealthToday.com, part of the DocWire family of medical news sites, and I want to thank you for tuning in to Urban Health Weekly. Our goal each week is to keep you informed of the latest in health and medical news right from today's headlines. It's time to empower yourself with open conversations about your medical care with news that matters to you. So are you ready? Let's get started. Hi, I'm Tamara Thomas, and welcome to Urban Health Weekly, where we talk about medical news and health topics that matters to you. I'm here with Jackie and Lou. How are you guys?
Very good. How are you guys doing?
I'm not so great, but how are you, Lou?
I'm doing fantastic.
Well, I'm glad you guys are doing so good. You know, we've just had nothing but bad news on top of bad news on top of bad news. And well, first of all, I had the opportunity to talk with chiropractor Dr. Sherry McAllister about non-prescribing providers like herself and how lack of access to them could lead to opioid addiction. And that'll be later in the show. But first, I wanted to share some of this bad news from across the country. Now, let me just run down the list of like the bad news that we have. We still have a baby formula shortage, even though Abbott is back in production. Organic strawberries are giving kids hepatitis B. There's an uptick in uterine cancer. There's like a shooting every other day.
Yeah.
We got the monkeypox thing going on. So, you know, I'm glad you guys are like in an awesome mood. I just feel like it's hard to be in like a good mood with like so much bad stuff going on. And it just seems nonstop every day.
Do you
But
think it's because you're informed about the stuff that's going on, as opposed to like,
I guess, you know, there is something to the ignorance being bliss, maybe.
Yeah.
Yeah, I think so. But you guys are informed and you're still in good mood. So maybe maybe I'm doing something.
if I think too hard about it, I am not in as much of a good mood.
Well, when you put it all together, it's just, you know, if you take them one by one, I guess it's like, you know.
All together, it makes me a little anxious.
Yeah, you know. So anyway, let's hop into it. So health officials are scrambling to raise monkeypox awareness ahead of Pride Month. Public health authorities are scrambling to raise awareness of the growing monkeypox outbreak in advance of Pride Month celebrations, which are underway. In doing so, they are trying to strike a delicate balance, getting out the message that monkeypox may currently be a risk to men who have sex with men without stigmatizing the community by linking them to a scary sounding virus that can infect anyone in certain circumstances. The message is similar for all communities, which is vigilance if you have a rash that is different or that could be monkeypox. Dimitri Daskalakis, director of the Division of HIV/AIDS Prevention at the CDC, told journalists. If you come back from the event and have a rash, it's important to get medical attention and just be aware that this is potentially circulating in some communities. All right, you guys, what do you think?
Well, it's you know, anytime there's a little sex or a little romance, or it's just all close contact. So yeah, everybody's got to be careful. Use all your precautions, wash your hands, et cetera, et cetera. If you've had smallpox vaccine, do you have any kind of protection for monkeypox?
You know, they're not really clear on if the smallpox, they are giving healthcare professionals the smallpox vaccine to protect them from the monkeypox. And it still remains to be seen if that's going to protect them. I don't know.
Right, it's curable too.
Sorry?
It's curable monkeypox. It's treatable. Don't waste your time. Don't wait. Go ahead and get that looked at.
Yeah, well, what they're saying is they think that it's been circulating a lot longer than we thought, because what they're thinking is that doctors may have dismissed it as something else and not realizing that it may have been monkeypox.
That makes sense.
Because if it shows up in the genital area, yeah. Then they're automatically saying, well, it's some sort of STD.
Right.
And they're not even thinking about monkeypox.
Yeah, who thinks about monkeypox until it's become like,
until you got the lesions breaking out, on your skin. Yeah, well, that's the thing. They're assuming that it was not monkeypox. Now they're looking at the monkeypox and they're saying, oh, it's monkeypox, but it might have been monkeypox all along, and they just didn't realize it was monkeypox.
Hey, did you get the smallpox vaccine, by the way, when you were a kid, or did you miss that window of because you're younger?
Yeah, I don't recall.
I did.
I don't.
Right. I got it because the cutoff was like, I got it as an infant when I was like 1, but they did it on my shoulder. But you had it, no, right? So
Yeah,
you
I
might have
didn't get
missed it.
that.
They stopped in the 70s, like early 70.
Yeah.
So
Yeah, okay, yeah, so I missed that altogether.
Yeah, I got it in
didn't
the
get that.
early 60s.
Oh, okay.
And I still have the scar.
yeah, so you have the scar on the shoulder. You have it on your arm, right? Yeah. Yeah, I don't have it because I guess I was too skinny at the time and they wanted to hide it in girls. And so they put it like on my back. So people have thought I was, younger than I am. Ha ha.
Check for that. When you go to the doctor, they would have you roll up your sleeve or whatever to show there weren't vaccine cards and records weren't that so
right.
And sometimes I didn't know what I had and didn't have because I traveled a lot as a kid, which ones I didn't get. So I just show them this and they say, okay, you got that one.
That's right.
Rolling.
Okay.
Well, I'm going to give you my thoughts on monkeypox.
Yes.
As long as I'm blabbing.
Yes, please.
And they start out with something a little bizarre. Like when I first heard about monkeypox, I honestly thought that this is the media again. It must be a slow news cycle this week.
You rolled your eyes.
No longer the elections or whatever. The elections are a couple of months away. So let's start a new pandemic and let's get a good one where it could be sexually transmitted. It has gay people are involved, so let's throw them. Let's throw somebody that gets it more than other people. Let's make a whole hullabaloo about it. That lasted for about a week. Then all of a sudden, credible doctors, and when I'm saying credible, at first it was like, eyewitness news. But then when, the scientific media started saying, no, hey, this is real. This is growing. I said, oh, wait a minute. This could be an epidemic. And the only thing that still kind of bothers me a little bit about this is such an easy thing to diagnose. I mean, when you have it, it's like having, an arrow right stuck in the middle of your forehead. How is it that people are giving it to other people? Is this easier to transmit than we think? Are we naturally transmit? What are the windows? All these things we like as you correctly said, Jackie, at the beginning, they think the smallpox vaccine will protect you, but they don't know. There's a lot of they don't knows about this right now. And I think that, my hope is that it goes away and we don't even talk about it because the cases just die out. That's what I'm hoping.
Right.
But if we talk about it again, I think A, we're going to have a lot more information, and B, it's going to be a lot more worrisome than it is right now.
So you think the monkeypox is a sexy name?
Well, it's, I'm not calling it sexy. I'm just saying it has a name, like the dinosaur flu or something. I don't know. It sounds.
It's ear catching.
Oh, it's ear catching.
Yeah, it's got a catchy phrase, or it's already got a cool name.
Not that I didn't hear everything else you said. Just that one particular part, I was just like, huh? Okay. Well, I'm glad you said that because I'm going to share my take on this, which is a little bit different from what you're both saying. And I'm incredibly frustrated by the CDC. I feel like they're not sounding the alarm enough on this outbreak. And let's be clear, it is an outbreak.
Okay.
And I really think it's for the same reason that no one cared about AIDS back in the day until it started hitting.
Oh.
I think you guys know where I'm going with this.
Yeah.
So the CDC basically said, nothing to worry about. This won't spread. It's not going anywhere. And I just really believe that they think that it's just within the gay community. It's another gay plague, and that's that. There, I said it. But that's my feeling on this. My feeling is that they're just not taking this seriously enough because it hasn't hit the burbs. This is the same thing that they did with the crack epidemic. Anything that doesn't hit suburbia, it's not a real problem until
feeling like it's
real Americans,
quote unquote
when
fringe
it's
group.
subgroups, then
Yeah.
it's not a problem. But then all of a sudden, when it gets into like the mainstream, then it's a big problem. You know, coronavirus, they didn't think that coronavirus was a big problem until it hit and crippled this nation. So I'm incredibly frustrated that we haven't learned lessons from the last pandemic that we're still in. That's pissing me off. It's incredibly frustrating, the level of ignorance that these people are trafficking in, and I just can't take it. That's that's how I feel about this. It's just, they've got to stop, and they've got to treat this with more severity, because this is going to hit the nation, and then what are they going to do? They can't just, you know, label this another like gay thing just because that's where they're seeing it. You know, this bothers me, and this should bother you guys too.
Do you think it's getting transmitted because it's sexually transmitted or can be?
But we just don't know enough about it. That happens to be where they're catching it.
But also, like, if you have a definitive
place it is.
If you have a definitive lesion and you're, getting it on in the dark, you're not going to see, you're not going to see that particular lesion. Maybe that's why, because Lou was saying it's a glaring, sign. I know it's,
but maybe it's not, because I don't think the incubation period.
Yeah, maybe there's some sort of viral shedding or whatever.
Right. By the
we
time
don't
you,
know. We don't know.
right, by the time you have the lesions, obviously no one's going to
It's
mess
too
around
late
with it.
now, right?
But that's the thing. It's like when you're in that incubation period and you just don't know, maybe, you feel like, oh, I'm a little tired, I'm under the weather, I'm gonna have like a little one of those little energy shots or whatever. Oh, I need some more
Right.
coffee. I mean, I don't know. They don't know enough about this, and that's bothering me, that they're not really taking this seriously. Like, if you look for a list of symptoms, the symptoms are like so non-specific except for the lesions. And you see pictures of people's hands with the lesions and all that.
Oh yeah, those pictures are really dramatic. But
how long did it take for us
how
to
long
compile a
before they
list of-
popped up?
How long, for example, did it take for them to compile a comprehensive list of all the symptoms of COVID? Right?
Oh,
Remember back in the day, when early aughts of the disease, when they didn't want to include loss of smell and loss of taste, and the ENT community had to fight and say, no, this is, and it's taking us out, because people are coming in with losing their ability to smell and their ability to taste, and it's making us sick. You have to add this to the list. And they fought them to finally get that added, right? And this is the same thing. Who's fighting now to say you've got to add these symptoms to the list? There's no one doing that, because it's just in the MSM community right now. That's all they know about it. And so now they want to tiptoe because they don't want to hurt anyone's feelings, but at the same time, they're not really doing enough to learn more about the disease. And partly, I guess, is because it's so damn infectious. Like, you could literally get it from bed sheets and stuff like that. But still, in the name of science, for heaven's sakes, we have to know more. Can you get it on a train? If you've ridden the New York City Transit, if you stand shoulder to shoulder with somebody, can they give you monkeypox? These are the kinds of things we need to know.
If somebody held on to that pole
after you did. I remember my sister, she got
oh, I remember that.
She licked her finger. She was eating a bagel I don't know why she was eating in public, but she licked her fingers. She had butter on her finger. She licked her finger after she got butter on her finger. She was holding on to the pole and then afterwards she was like, oh, what did I do? And then she ended up getting a horrible throat infection, strep throat. She got strep throat from the subway. Don't tell me that you're scrambling to raise awareness about monkeypox. No, you're not. Not when you put out a statement 2 weeks ago saying that there's nothing to worry about. And then now you come back and you're trying to figure out how to talk to a community about it. You should be talking to the whole nation about it, not just the community. That's ridiculous. Have you learned nothing? So that's all right. I'm off my soapbox. It's just been an incredibly frustrating experience to watch the coverage of this, because we really don't know anything.
You just feel like it's history repeating all over again.
It's just a little bit of history repeating itself, like that song. It's all just a little bit of history repeating. I shouldn't be laughing because I'm upset, but yes, it is. And I just wish we knew more. and we don't, because they're treating this like this is an isolated thing. And we've seen this happen so many times before. That's all.
Okay.
Speaking of,
Why don't we take a break before our next?
you mean you don't want to talk about the syphilis epidemic?
No, absolutely don't.
Okay.
But we'll be right back.
I'll
We're
be
gonna
back
talk about
We'll be back
syphilis.
with more bad news after this. And we're back. And we were just regaling you with some bad news, and I've got some more bad news. The syphilis surge is now a public health emergency, or at least should be viewed as a public health emergency. While the trajectory, by the way, I thought this was a disease that was like on the downslope, but
It was for a while, wasn't it?
yeah, it was for a while. While the trajectory of the pandemic remains uncertain, there is no shortage of other health topics that need urgent attention. Arguably, one of the next public health emergencies will be responding to the increase in STIs. Even before the COVID-19 pandemic, STI rates were on the rise. As health systems return to pre-pandemic delivery of services, the ongoing upward trajectory of STIs is coming into focus. Most alarming is the resurgence of syphilis, known as the great imitator, for the challenges it presents to clinical diagnosis. The latest rates suggest that far from the plans to eliminate syphilis in the 1990s and the 2000s, the disease has once again emerged as a public health threat. According to recently released CDC data, cases of syphilis increased 52%
That's huge.
from 2016 to 2020, and congenital syphilis cases are up by 235%.
Wow.
Preliminary data for 2021 show yet another increase in congenital syphilis, considered a sentinel event in the healthcare system. This growing infectious disease threat deserves urgent attention. Untreated syphilis has severe long-term health consequences and contributes to HIV transmission. Congenital syphilis leads to greater rates of stillbirth, premature birth, and infant death. Infants who survive can have lifelong disabilities from the infection. Let me just say this. C. Everett Koop, you remember C. Everett Koop?
Yeah, I remember him.
He was the Surgeon General, I think, under President Clinton. He scandalized America when he deigned to advise that people use condoms. I thought he was my hero when he said that. But somehow condoms have just fallen out of favor, and I don't know when or why or how. All I know is this hookup culture is driving these spikes in infections. Let's just call it what it is. Oh, can we agree that it's the hookup culture?
Is it the hookup culture? I want to say something. If you get, well, okay, yes, I acknowledge that. But if you go to the doctor, because, you know, I'm the most nervous person in the world, so I always would go and get tested for everything all the time. And so I would ask, you know, they didn't have a syphilis test. You had to ask separately for that. That wasn't a standard panel. That really,
wow.
No, it wasn't. So because a lot of places they would just test for everything, but they wouldn't necessarily give you blood work. And then if you're going to get your regular complete blood count, blah, 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 you had to go get a separate test for syphilis. So it wasn't convenient.
Is that if you went to your is that if you went to your private doctor or your private women's health doctor, as opposed to like if you went to like Planned Parenthood or something? Because at Planned Parenthood, I recall, did like a really comprehensive, it was almost embarrassing.
Did they do blood work? Because
they did
I don't remember them doing blood
culture.
work.
They did every culture known to man, your throat, your everything, from the rooter to the tutor.
Really?
Yeah.
Because I remember having to go separately for that. And and not only that, that wasn't necessarily covered right away. Like you had to, a lot of places that had women's health didn't necessarily do that automatically, even if they tested for other things, because other things were a swab, you know?
Oh, that's
and so I like the idea that they could bundle that test and make it just like really a standard thing. It, you know, they had to code it separately if you wanted like a syphilis test, it had to be.
And then you had to be like a certain group, right? Like you had to be like a high risk group.
Right. They would ask you too many questions as opposed to just be like, yeah, just automatically test. You know, like you're already like a little mortified.
Okay, so now you're raising an interesting point.
maybe that's because it was New Jersey. I don't know, but
Back
you
in,
know,
back in the day, by the way, Sierra Coop was Reagan, 1982 to 1989.
Oh, thank you.
Yeah.
Thank you.
But one of the things that, and he was a pioneer in eradicating a lot of venereal disease and stuff like that. But one of the things about the syphilis test is that it's very, very, very painful. I never took it. I
Then
just
how do
know
you know that it's painful?
people that I know took it. They didn't like it. They had to put a swab, and this is back in the day, back in the Middle Ages when I was,
They put a swab down your urethra.
you got it. And
what?
I didn't want to say it because it just hurts to say it. And at the end of the day, it was like you would just decline it unless you had some sort of symptom. And they used to give you like these whole things, like syphilis was called the drip. You
Right.
could either have the
Oh.
drip or the clap.
Right.
Every
I thought gonorrhea was the drip.
not the drip. Look, I had neither. So one was the drip and one was the clap, and either they were both supposedly bad or
Wow.
whatever. And thank God I never had a test. But
Didn't they used to do blood work though? Like when people get married, they had to get blood work. They
Right.
had to pass their test. But that I don't know that that's necessarily.
No, I don't think they do that anymore. I think it's like, yeah, more power to you. I think it just became expensive, or maybe just people objected to it. I don't know.
yeah, because if you had syphilis and you didn't know it and you didn't treat it, that's
Right.
and
Because eventually it would get to your
It's
brain.
horrible. Goes
Yeah.
latent. It's terrible. Yeah. Wow.
Ooh-wee.
So
Yeah.
I thought it was tested by blood. I didn't know you had to go through this whole.
well,
Oh,
I'm
they
sure
swabbed you for well, when in my experience, they swabbed you for the gods and they swabbed you for everything. But I'm a little younger than you guys, so maybe by the time,
Maybe they were a little more.
yeah. But I went to Planned Parenthood and places like Planned Parenthood because that was all I could afford back in the day.
Right.
And I wanted to stay on top of my I stayed double bagging, but just to be, that means wearing 2 condoms for
Yes.
those of you who don't know what that means. Yeah, and so, but I still wanted to, because I was just so concerned, like I didn't want to have something that would destroy my reproduction or
Right.
just take me out of the game or whatever. But in any event, I would go to, and I would get my care, and they would do like a full panel of everything, blood, swab. It was
They
really
did blood
humiliating.
work too. Okay,
Yes.
that's good.
It was very humiliating, but they did it. And, I believe one of the tests they did, I don't know, this was so long ago, but in any event, I don't know. I think a lot of it is this whole hookup culture now. I think you're right in that if you don't test for it, then you don't know about it. That's kind of what you guys are saying, right?
right. 'Cause
Yeah, but I hadn't thought of like the hookup culture. Are people like not using condoms anymore? And
I
also,
don't think
still
so.
no
It's
guarantee.
not part of the lexicon anymore. Like
It's
when I
also
was
not a
coming up-
guarantee. I mean, you can still get like, all kinds of things with condoms, but it makes a big difference to use a condom. It's definitely what you should be doing. You're saying you think people aren't even using them, or
I
they're
don't know that people are. And then, like oral sex also is another a way to give it and get it. And, that's rampant too. And I think people think that there's not as much risk in, by the way, did you know they created a panty, like a latex panty? It's like it's like a dental dam, but you wear it as a panty. I don't know how smart that is, because my immediate thought was like yeast infection. But like if you wore a latex panty, no matter how thin it is, at some point in the night, you're going to be trapping a lot of moisture down there. I see the wisdom in it, but
you
when
need
you
to put it on right then.
well, that's the thing.
Right.
Hold on. But then that's the same thing for a dental dam. Like, are you gonna pull it out right? A lot
Or
of
a
people don't
condom,
do that.
right?
Well, that's the thing, and we need to get back to that. That's what I'm saying. We need to make condom use and prophylactic use
Habitual.
and barrier use habitual, like it used to be when I was coming up. When I was coming up in the 90s and the 2000s, it was nothing. Every way you turned was condom, condom, condom. Protect yourself. Protect yourself. You don't want to get a disease. Every song, it was just ingrained.
Yeah.
You don't want to get prematurely pregnant, use protection, protect, protect, protect. And now that's gone. I don't hear that anymore. I mean, I don't watch VH1, I don't watch MTV and those, except for my RuPaul's Drag Race. That's different. But I don't watch those. But I don't think that they are talking about protecting yourself. I think it's just all this romanticized, like, devil may care hooking up stuff. And I know I sound like a fuddy-duddy when I say it, but I don't care because I think it's extremely important. That's all. I just think it's extremely important.
Hear, hear.
Now, I talked to Dr. Sherry McAllister. She's a chiropractor, and she's president of the Foundation for Chiropractic Progress. So let's take a listen. Hi, I'm Tamara Thomas, editor-in-chief of Urban Health Today, and I'm speaking with Dr. Sherry McAllister, a chiropractor, practicing chiropractor, and president of the Foundation for Chiropractic Progress. She's here to talk with us today about how disparities lead to opioid addiction. Thank you for being here, Dr. McAllister.
My pleasure. Thanks for having me.
Awesome. Let's get started. So tell us your story. First of all, can you tell our audience what a chiropractor is and does?
Absolutely, my pleasure. A chiropractor is a physician, a healthcare physician who takes care of the spine and the well-being of the patient. So it is a fundamental review of the neuromusculoskeletal, which is the nerves, the muscles, and the bones, to ensure that the patient is at optimum performance. So we prevent injury, but most importantly, we also care for the individual as a whole.
And do you want to talk a little about how you made a difference in the community that you were in?
Absolutely. Well, one of the things that we're starting to find is in chiropractic, it's on the rise. And that means that we're increasing our research, which was a fundamental piece to being able to showcase the objective findings that patients are going to need to have the trust in chiropractic care. The other portion of this is that patients are now looking for non-pharmacological options. They don't want to rely on a pill. They want a natural chiropractic approach to their well-being. And as we look through and we think about satisfaction rates, where patients are finding the greatest satisfaction, chiropractic actually is one of the top healthcare providers with satisfaction rates. And the last piece, I think, is the important patient-centered approach where the patient really comes to the doctor and has the time spent with that doctor to really discuss what their needs are. Not what the symptom is, but what really is going to change fundamentally how they deal with activities of daily living and how they're going to approach their overall wellness plan.
Why, or do you think there is a reticence on the part of physicians to refer, because you're considered a non-prescribing provider or an NPP? Why do you think, or do you think there is reticence on the part of physicians to refer patients to NPPs such as yourself?
I think this is an extremely important question that needs to be backed up with a couple of pieces of information before we jump right into the reticence. So yeah. I want to look at a study that was done by the BMC. It's Complementary Alternative Medical Journal. And here's some of the facts that I think your listeners will be interested in. 81% of doctors of osteopathy and 87% of medical doctors actually reported that their patients had asked them for information for chiropractic. We're going to use that as our example because that, of course, is what I know as an expert in this field. Close to 75% of primary care medical physicians had patients who actually requested a referral to a chiropractor. Now, why is that important? And here's the kicker. 24% of doctors of osteopath and 29% of MDs had formally referred a patient to a chiropractor. So when you ask about reticence, is it in just that one study? Does it not show reticence more on the referral than it does the actual consumer? And so the common reasons that patients want to get this kind of referral is for back and neck pain, or kind of that unresolved chronic pain.
Mhm.
Many of those musculoskeletal conditions, and the vast majority of those DOs and MDs preferred that their patients contact chiropractors on their own, rather than actually making a physician-initiated formal referral themselves.
That's
So that's,
interesting.
I thought that your listeners would find that interesting, because it's showcasing where is the potential barrier for that
Right,
patient to get non-pharmacological care. Because if it happens, in fact, for chiropractic, it's happening for physical therapy and acupuncture
right.
and cognitive behavioral therapies as well.
And this is important because if the physician does not provide the referral, then the chances of the insurance paying for it are very low to not at all.
It can be in very many circumstances when a referral is absolutely necessary.
Right.
Plus, it also starts to then degrade the patient's trust on non-pharm options if the doctor is not in it. And we know the American College of Physicians noted that it should be, in fact, a non-pharm option first. So if the doctor's not referring, and the guidelines are saying non-pharm options first for musculoskeletal issues, what's happening? And what is the reticence? And I think we can explore that a little bit further.
Yeah, absolutely. I'm all ears.
So as we kind of go into this world of education, think back to, how do you know about something? How do you actually find out about a new option? It's usually word of mouth or by the media. What's interesting is that the pharmaceutical companies, for the major media, is investing hundreds of millions of dollars into their commercials. It's very rare you can open a magazine without finding a pharmaceutical commercial involved in it, in hard copy, or even on your regular channel of the News Watch. So they're explicit in educating the consumer, the pharmaceutical companies, that pharm is an option. So they're getting all of their education, and all of that word of mouth is, hey, I just listened to that commercial, I have some of those symptoms, and wham, what are you thinking? I'm going to go to my primary care and ask for that drug, right? The second part is, and this kind of was an interesting eye-opener for me too, is how often do the big pharms actually sponsor large medical conferences? And for your audience, this is not a hard one. If you, in fact, Google big pharm and sponsorship of medical conferences, the first note that actually comes up is 41 out of 47 medical conferences were sponsored by big pharma. Let's go back to thinking about, how are our primary care physician medical doctors and our doctors of osteopath being educated? They're being educated by the sponsored conventions that are big pharm. Big pharm is massive, hundreds of millions of dollars in media, consumer education, medical doctor education. They're in the medical schools. And the other portion of this is the lobbying. How do you get laws passed? So when there's reticence, is it education, or is it just a drowning out of a small voice of non-pharmacological options? And that, I think, is something we all have to consider, because it really does make a massive difference if the consumer is aware that there's a non-pharm option out there.
And then the other problem is that the opioids, they don't really get to the root of the problem. They only relieve the symptoms, which is the pain, but it doesn't get to the underlying cause of the pain. And so how do we get physicians? Is this a patient-led experience where the patient has to insist to the physician? Because now we understand the impetus for why physicians are not referring patients the way they should be. Does this need to be led by patients then?
I think one of the major ways we get our information out is through pieces like this. And so I applaud you for even having this episode, because how are the consumers going to find out? if we know that the medical doctors are being turned towards pharmaceutical options through their funding of their continuing education, we know our magazines and our media are being filtered through the eyes of the pharm. So I think that the options have to be out there, and the way to get this information out is going to be word of mouth. It's going to be hard pressed, honest, factual information. And the things that make me step back and think, what's really happening out there? The CDC proposed to remove this year the recommended dosage caps on opioids for acute and chronic pain. Now, this is a drastic change from 2016 guidelines, which actually recommended 90 MME, that's morphine milligram equivalents. And for your audience, that actual equivalency level was set to determine whether that cumulative dose puts a patient at risk of overdose for a new patient. So one of the first things we got to look at is, why would they take away the highest level of equivalency if they know that that was to determine whether a patient had a risk of overdose? And I think as we start to look at how medications are prescribed and how non-pharmacological care needs to be first, it's still not first. And I think when we start looking at putting it first, we need to know, is it effective if we put non-pharm first? And why are the patients not using it?
So how aware would you say patients are currently of NPPs such as chiropractic and acupuncture and
well, I think they're increasing their awareness because the number of patients that are using chiropractic has definitely grown over the last 10 years for sure. And one of the pieces that I think has helped to ensure the growth is actually the patient satisfaction rate. And I'll tell you a little story that I think is quite fascinating. Is there is a university healthcare system in Florida where there's 1,500 healthcare professionals that work in that environment. One of those healthcare professionals is a chiropractor, and she works in the traumatic brain injury, Dr. Susan Welsh. And this particular institution won a Press Ganey Award. And one would ask, well, what's the significance of that? And that is, in fact, 100% patient satisfaction for what that healthcare provider actually touched the lives of.
Wow.
And that was the first time that institution ever won it. And it was won by a chiropractor. Now,
that's amazing.
That is an amazing story in and of itself. And I very much agree with you. But listen to this. That's the first time in 35 years of that institution being open they ever even knew there was an award. And it gets better. This year alone, she won it again. So I think the statistics are startling. 2-time winner of a Press Ganey Award. That patient satisfaction rate is really impressive. And there's a study that was done by the Palmer, the 2016 Gallup Palmer chiropractic research, and it actually reported that 95% of recent chiropractic users rate chiropractic effective. So if you have this small but very important group study that showcases the importance of that usage, it's starting to slowly seed and bloom. 97% of past year chiropractic users are likely to see a chiropractor if they have neck or back pain, which means not only are they using it, they know that if they have an issue, where to go to get that non-pharm option. And I think that's one of the pieces. In fact, Consumer Reports came out with how many people were suffering with back pain. And they gave a number of the survey that they put, it was approximately 3,500 sufferers. And they asked them a question about chiropractic. And 83% of the respondents had seen a doctor of chiropractic, and they found the treatment or the information they received from that doctor of chiropractic to be extremely helpful. So when Consumer Reports, that wasn't friendly to us in the early 80s, is now showcasing that the patients are voting with their feet, it means that our patients are starting to recognize one thing. An opiate is not an answer, it's a symptom reliever. When you think about quality of life and the ability to carry on with your quality of life, it's scary. And I'll tell you one more story on this particular fact. I was in Maine and there was only one taxi driver available to take me to this very small little airport.
Mhm.
And she asked me why I was in town, and I told her I'm educating the healthcare providers about the use of non-pharmacological care and that we're trying to reduce the usage of opiates. And she said, well, she said, that's all I have available to me. I take 4 Vicodin a day. She's 67 years old. She now has heart
Wow.
issues. She has diabetes. She has all sorts of complications, particularly, and this is not a joke, is constipation. Why does your body slow down when you take an opioid? So that you can't release the toxins in your body. It's a thought process that you have to go through. And I said, are you ever offered any other options? And the answer was startling. The answer was no. How are we in 2022 having a taxi driver on an opiate, which, decreases your ability to really pay attention? So the safety of America is at risk
Right.
when you're using an opiate, or worse. I was watching the Lincoln Lawyer last night on Netflix,
Okay.
and it was kind of an interesting thing because the driver that the Lincoln Lawyer had, she was a dancer, and she ended up on the streets using heroin because when she was dancing, she hurt her back, and she was an international performer.
Mm.
She was feared into losing her job, and she did everything she could do to save her job. So to continue to do her activities of daily living, she took that Vicodin, and that Vicodin led to opioid abuse, and that opioid abuse then led to her being on the streets. And that's a common story. And I thought it was interesting that the Netflix piece showcased it in exactly what's happening in today's world. Fear of losing their job, fear of activities of daily living being compromised, and the fear of the pain if not properly being treated.
I have to tell you, speaking of driving, about 20 years ago, I had hip pain actually, that was because of my back. And the way I found out about chiropractic was I was talking to a girlfriend of mine, and I was telling her about my hip and that I thought it was related to my back because I just started driving at the time. And she recommended a chiropractor. And I have to tell you that it never occurred to me to take pain medication for it. I can't conceive of a world where I don't have access to chiropractic care, because there are a lot of us that don't believe in medicating a problem away, right? And there are a lot of us that if a doctor said, well, hey, this is your only option, we'd be like, no, thanks. And so it was to me, it just sent my mind in a complete, like I can't conceive of taking a pill for something that can, someone laying hands on me and adjusting me can fix. Like I can't wrap my mind around that. And my heart just goes out to people who are put on this path, because it is a path that leads to addiction, unfortunately. So in your experience, do you think it would make a difference in the levels of addiction we're seeing if patients were encouraged to seek out chiropractic and other NPP care prior to being prescribed opioids? Does that world exist?
Absolutely. First, I am so grateful that your girlfriend stepped up and stepped in. She was brave, she was bold, and it's beautiful that you're not on that path, because you easily could have been on another journey. And in fact, one Harris poll that we did from the Foundation for Chiropractic Progress actually pointed out that our Gen Zs are much more likely to want a non-pharmacological approach. And that is heartwarming because that's our future, but our future has to be made in objective reality. And so when I look at some of the studies that came out, for example, one is in the Journal of Spine in 2021, author Waden, and he actually pointed out that in the initiation of getting an adjustment, otherwise known as a spinal manipulation for treatment of, for example, what you had, low back pain or hip pain, the harmful medication related incidents occurred 42 times more often in patients who were first
Wow.
prescribed opioids, as opposed to patients who, like you, received an adjustment, a chiropractic adjustment. So it's there. Another study that he did in pain medicine, Waden in 2020, actually showed that there was half the risk of filling an opioid prescription if, in fact, you saw a chiropractor first. And that really makes a difference. Last one I want to point out in pain medicine is through Kokorin, and the answer was chiropractic users had 64% lower odds of receiving an opioid prescription than non-users. Those are facts, and facts have to be where we go. And our younger audience is looking for that natural approach. They want to have a fun-filled life that is not dependent on a pill. And I'm grateful that it's word of mouth. Because like I said, we can't compete with the amount of money that's being put into the lobbying, put into the medical communities, and the advertising that is being done. And when we talk about non-farm industries, we're kind of looking at that big picture of how do you find out that there's a non-farm option available to you, because the barriers to getting it are massive.
So what should people be saying to their, if they have a primary care doctor, what should people be saying to their pain management healthcare professionals? What do you say? So I come in, I see my primary care doctor, or I see the doctor, the urgent care doctor, and I know I have back pain. I don't want opiates. What's the conversation I'm having with this provider to get them to refer me for chiropractic because my insurance requires a referral?
This is one of the key moments in building trust with a patient. It is a guideline recommended by the CDC and the ACP, the American College of Physicians, that non-pharm options are given first. So if a patient is handed an opioid prescription, then the patient should stop and say, my understanding is with low back pain that I should probably try a non-pharm option first. I would like to see a chiropractor. I would like to see an acupuncturist. I would like to see massage therapy, a physical therapist, cognitive behavioral therapy. You have to be ready, willing, and able to ask these questions to your doctor. How can I get my non-pharm option first? And be ready with your own choices, because you have to vote with your feet. And one of the keys that we're seeing right now is our primary physicians, our primary care physicians are actually burning out. And you
Yes.
know, the Surgeon General came out with a new advice addressing the urgent need to address healthcare workers' burnout crisis across the country. So what's happening is they're seeing more patients than they can handle. They're being impacted acutely by the COVID-19 pandemic and the opioid epidemic. It has to be very trying. It has to be very, very difficult for these primary care physicians, and trying to help patients in that industry, especially when we're coming to a primary care physician shortage. So we want to change the conversation. And I'm grateful that the Surgeon General had actually sounded that alarm, because I want to know that my primary care physician is top notch. They're fully energized and wanting to help me with the best that they have. And we need to strengthen this community with the primary care physicians knowing they have options for referrals, the insurance company working, because we know the cost variation. It when you look at the changes in the cost, it's amazing. There's a Blue Shield Blue Cross study that actually showcased the amount of money that could be saved if patients were going to non-pharmacological options first. And the outstanding moments come when good people can do great things and they start to put the patient first. We take care of our primary care medical physicians so they're not burned out, that they have the right information about non-pharm, and they have an easy referral system in place. And I think when you start putting all of these pieces together, we're going to help our aging adults, the Medicare patients that were given opioids. Can you imagine an elderly who's already naturally losing their balance,
Yeah.
given an opioid as a
Right.
non-pharm option first? That's
And already
tragic.
has digestive issues, exactly.
Absolutely. So we have a patient who is well educated, thanks to your podcast, that will go in when they need primary care or they want to optimize their wellness and they go to a non-pharm option first. They build a relationship with a non-pharm option first before they need it. Because it's too late sometimes when you're in severe back pain, it's too late to try to figure out how to get into a non-pharm option first. You want to break the barriers down first before you end up having to be in an acute care setting where you're going to need a non-pharm option. So I would encourage your listeners, find a trusted physician that will not be prescribing an opioid first. And that's going to be your non-pharm options, your chiros, your acupuncturist, physical therapist. I open the door to anyone that wants to find help that doesn't involve a pill first before you need it. And chiropractic, for an example, is all about optimizing your wellness. Have a relationship with a physician like that first, so that when you absolutely have an injury or an illness, then you can get in. You know, you understand what the deductible is, what the copay is, what the time is involved in getting there. These are all barriers to care. Break those barriers before an acute episode happens or a chronic issue begins first. If you're suffering right now, I would say pick up the phone, find a non-pharm option, or go to our f4cp.org/find a doctor on our website. You can find someone to help you, and you have to be educated and ready. And sometimes you'll be educating your primary medical physician to say, no, an opioid is not my choice. I want to try something different. Can you help me get the referral that I want, the referral that I need to help my low back pain, my neck pain, or whatever it is that you're suffering with that you think that you'd like to try another option first?
I think it's also about taking the decision out of the HCP's hands, right? Because if you have a physician whose orthodoxy is prescribed and you don't have access, let's say, to a non-prescribing doctor or a doctor who doesn't believe in prescribing, then you've got to push back. You've got to have that conversation. You've got to stand strong and say, no, this is not what I want. I want to do this. I don't want, and be prepared to say, I don't want to become addicted to opiates. I don't want, this is not going to solve my problem long-term. And have that conversation with the doctor and stand firm, right?
Absolutely. In fact, you brought up something that I think your listeners will be surprised by, and it is a study of a managed care company, United Health Group, and it found that in the American Southeast, the back pain was treated with opioids at a far higher rate than in other regions. And when you dive deep into the findings, what did they actually find? Zip codes with no non-prescribing providers had the highest rate of opiates. That tells you something right there. The
Right.
lowest average for income earners were given the highest opioids. The highest percentage of non-white population, which was very important. In the Southeast, they have less non-prescribing providers such as chiropractors and physical therapists. But here's the key. There was a piece in there that showed in Atlanta that 58% of zip code variations in opioid prescribing for back pain can be explained by income, race, and accessibility to those non-pharm. And one of the things that I thought was fabulous is they actually found one area, one zip code that puzzled them on why they had the lowest number of opioids prescribed. So they dove deep into that zip code. And you know what they found?
They found
one,
Mhm.
they found one Black community zip code with a drastically lower rate of opioids because there was a single Black female chiropractor that said, no opioids first. We're going to treat you. We're going to ensure that you have the exercises, the stretches, and the well-being to carry on in your activities of daily living before we go to an opiate. So I definitely don't want to come across like non-prescriptive treatment is a silver bullet for the opioid crisis, but it's clear that it actually can reduce prescribing while still addressing the pain management needs of today's patients.
What can more NPPs do? Do you think it would be beneficial to have relationships with the HCPs in their area to raise awareness, to say, hey, I just want you to know I'm here. And, you know, if your patients have these kinds of pain symptoms, they can come in and see me. Do you think that would be beneficial?
I absolutely do. And the Mayo Clinic has a study that integrative health in working with non-pharm physicians is a critical component to helping a patient-centered approach. So we have to, as non-pharm prescribers of taking care of a patient, reach out to our healthcare providers. And one of the things I like to do is my LinkedIn page, Dr. Sherry McAllister, is put out articles that resonate with my healthcare community. And I'm in Silicon Valley. We have fabulous physicians across the board, from orthopedic surgeons. I have patients that are orthopedic surgeons, nurse practitioners, and some very famous researchers who are really quite amazing in and of themselves at Stanford University. And I really enjoy the conversations that we have. But my goal is to educate them every time they're in the office, to collaborate with my community, whether it's a yoga instructor or a orthopedic surgeon. Ask them for coffee, show them the research. I'm amazed when I go to national conferences. Last one is in Washington, D.C., that the research isn't getting out there. The healthcare providers aren't reading what is actually out there. And your audience now has heard some of the studies I just quoted, and many of the healthcare providers have no idea. And I once had a fabulous interaction with the president of one of the pain societies. And he asked me point blank and very seriously, he said, I don't understand why chiropractic is so high on patient satisfaction rate. And I said, well,
Doesn't understand.
Because they're in the 60s and low 70s, and the
Okay.
chiropractors are in the high 90s. Patient satisfaction rate comes with two things: trust, and we touch our patients. It's not a prescription pad. Here's your pill and you can go away. It's looking in the eyes of that patient who's suffering and trying to figure out what is the best option for you, and trying to ensure that their future's bright and that they can depend on themselves to be able to carry on and do what they love to do. And what does that mean? And healing a problem and not just covering the symptoms, that's a critical component to vitalism. And that's how we all thrive in today's society.
Thank you so much, Dr. McAllister. People need to hear this. And so I'm so glad you came and talked about this today, because as I said, I can't imagine a life where NPPs and chiropractic, and I mean, I've done chiropractic adjustments. I've seen an acupuncturist. I've had, PT and OT for a broken hand. So I can't imagine a world where your only choice is opioids. So this is important for people to know that this is not the only option out there. So thank you very much for your time today. I really appreciate this.
extraordinarily grateful to be able to share this information and very proud that you're willing to help your audience make better choices.
Thank you. Thanks for listening to Urban Health Weekly today. I hope you'll join me and my friends next week so you can stay informed and inspired to take control of your health. See you next time.